I first want to apologize and say that normally when I do talks like this, I wander around a lot. I like to not sit still, but unfortunately, the Zoom technology forces me to sit still. So I'm gonna try. What I'm going to do is talk for about half an hour, maybe 40 minutes, and then give lots of time for questions because I suspect there'll be a lot of questions. You know, they like to say that growing old isn't for sissies, and that was before COVID-19. Now we've all got to be really tough. We've had to learn a whole new language, flattening the curve, social distancing, PPE, contact tracing. We've learned that going to the store in a mask is a sign of social solidarity, not a tool for robbing the place. We've had to deal with shortages of toilet paper, and we've had to learn Zoom. None of it's easy. More seriously, as everyone knows, older adults, especially those with chronic medical conditions, are at an especially high risk of dying from COVID-19. As far as we know, they're not more likely to contract the disease, but they are more likely to die if they do. Risk is not age-based alone, but principally based on pre-existing conditions, such as hypertension, obesity, or pulmonary and heart disease. Older adults are not at risk because they're old. They're at risk because they're more likely to have these pre-existing conditions. And as we've learned, this is especially a challenge for African Americans, who are even more likely to suffer from these kinds of medical conditions. But short of death, COVID's creating enormous challenges for those of us living at home, as well as those living in facilities such as nursing homes, assisted living, senior living communities, and continuing care communities. Some have become deadly hotspots for spread of the disease. The Washington Post reported the other day that 7,000 nursing home residents have died from COVID-19, and more than 1,300 facilities have reported COVID cases. The Wall Street Journal reported yesterday that 11,000 people have died in all long-term care facilities. And that's about 1/4 of all deaths in the United States. And I'm sorry to say, but these numbers are almost certainly low. I think when all is said and done, we'll learn it will be much worse. An industry survey that was taken last week found that 1/3 of nursing homes reported COVID cases among staff or residents. So it's far higher than what the Washington Post found. And that implies that 5,000 of the nation's 15,000 nursing homes have COVID, either of staff or of residents. In Belgium, which is way ahead of us in terms of experiencing the disease, 90% of senior living communities have reported COVID-19 cases. Now, we also know that once the virus gets loose in a facility, particularly a closed facility like a nursing home, it becomes explosive. There's older research on the seasonal flu that shows that as many as 1/3 of residents and 1/4 of staff will contract the flu once it comes into a facility. And remember, of course, that for the flu, there's a vaccine, and for COVID-19, there's not. In the US, we don't know for sure how bad the problem is because the federal government does not require nursing homes to report COVID cases. On Sunday, the government said that it would begin to require that disclosure, but it hasn't done it yet. And the industry already is pushing back against what it says would be onerous requirements. States do require reporting, but many refuse to make that information publicly available. We know even less about assisted living, where there's no federal reporting and little state reporting. Infectious diseases in nursing homes and assisted living facilities are not a new phenomenon. We've seen it with seasonal flu, and we've seen it with norovirus, which is a really nasty intestinal virus. It's interesting, norovirus is sometimes called the cruise ship disease, but in fact, 80% of US cases of norovirus occur in nursing homes. In one 4-year period, there were 2,000 nursing home outbreaks of the norovirus, 20 times more than there were in hospitals. The truth is, many facilities have had serious problems with infection control long before COVID-19. They suffer from lack of staff, and there's a lot of research that shows that, that there's a close relationship between the number of staff people and infection control in a facility. They suffer from poor training. Staff still don't wash hands when they go in and out of a resident's room. They suffer from a shortage of personal protective equipment. We've learned about all this, of course, in recent weeks. But the truth is that gloves and masks, that sort of thing, often were unavailable or not used by staff. The other thing, of course, we're learning with COVID-19 is about testing. And we've learned that it's very hard to get. As hard as it is for hospitals to get, it's even more difficult for nursing homes. And it's not just a matter of getting the tests, it's also a matter of getting rapid results from the tests. Sometimes facilities can wait a week or longer before they get results. I talked to one operator the other day who talked to a lab and asked how long it would take to get results, and she was told 3 to 10 days. So even when you can test, it often takes a very long time to get the results. And then, of course, there's the nature of the living arrangements themselves in nursing homes and assisted living facilities. There often are shared rooms, especially with Medicaid patients in nursing homes. There's communal dining and there are day rooms. In normal circumstances, these are very nice, but when there's an outbreak of some infectious disease, it becomes a real crisis. The other problem with nursing homes is that most facilities combine long-stay residents, many of whom have dementia, with those patients who are there for acute or post-acute care, such as getting rehab after a hospitalization. And that means, in the current circumstance, that many of those patients could be bringing COVID-19 in from the hospital and putting long-stay patients at mortal risk. All of this makes nursing homes a perfect petri dish for infectious disease such as COVID-19. Now, the other consequence of COVID-19 in senior living facilities is that those communities are on lockdown. They're not allowing any visitors except for the most extreme circumstances such as end of life. And that means more social isolation and more loneliness. And the truth is people will die of that too. It also means that there's no one to put eyes on the facilities or advocate for residents. There are no families there. There are no ombudsmen. Not even the regulators are coming in, with the exception of inspections for facilities that have serious problems or for inspections they're doing for infection control. Other than that, the regulators aren't coming in either. So about now, you're probably saying, I'll never move into a nursing home. You'll never get me in ever. In fact, relatively, even before COVID-19, relatively few people actually did get their care in nursing homes. Best estimates are that 85% of older adults who have personal care needs get that care at home. About 20% of them use home health aides. But there's more bad news. Home care agencies themselves have many of the same problems that nursing homes have. They have their own infection control problems. Their shortage of PPE is probably more extreme than the nursing homes. They're at the bottom of the list after hospitals, after first responders, after nursing homes, and then if there's anything left, the nursing home operators or the home care agencies get them. The other problem, of course, is that aides go from client to client. You may have an aide who's got 4 hours a day with one client. They may go to 2 or 3 others, or they may actually moonlight in a nursing home. So they could unwittingly spread the disease among their own clients. And they too suffer from limited testing and long waits for results. The other problem they're having is with staffing. Many staff are calling in sick. Many staff aren't coming in because they're afraid of the disease. And then there are many who are just staying home because they have to care for their own children because school is closed. And when you think about it, these aides are being paid on average less than $10 an hour. And you have to ask yourself, you know, would I put my life and those of my family at risk for $10 an hour? The basic problem is that our system for caring for older adults, or in fact, younger people with disabilities, was a mess even before COVID-19. Coronavirus has only exposed and magnified those weaknesses. So let me step back a bit and talk about some broader long-term trends that got us here. First one is actually a very positive trend, and that is that we're living longer than at any time in human history. Just since 1950, life expectancy at age 65 has increased from less than 14 years to more than 19 years. In other words, in 1950, you would live, if you made it to 65, you'd probably make it to 79. Now, if you live to 65, you'll probably make it to 85. And that's thanks to extraordinary improvements in public health and medical technology. Just one example, from 1989 to 2015, the mortality rate for women with breast cancer dropped by 40%. It's a remarkable number, 40%. But that's created problems. The first is that our health system has not yet adjusted its focus from acute care to chronic disease. course, right now we're having an acute care problem, but in general, the story of healthcare in the United States is one of chronic illness and managing chronic illness, and the health system is not prepared to do that. The second is that our ability to care for people who are living many years in old age lags our ability to keep them alive, and that's not a good thing. Just to take one very difficult example, a man who might have died of a heart attack at age 50, which was not uncommon 50 years ago, now lives long enough to get dementia, and we don't know how to care for him very well. And when you think about this kind of care, age is critical. Only 10% of those age 70 to 74 will need some level of personal assistance. By the time you reach 85 to 89, about 44% will need it, and 2/3 of those over age 90 will need long-term services. Overall, about 12 million people will need this kind of support, and that number is going to double over the next couple of decades. If you think of it as an individual, 2/3 of those 65 and older will need some level of personal assistance before they die, and half will need a high enough level of care that it would trigger long-term care insurance benefits, or they become eligible for Medicaid if they otherwise qualify. On average, men need this care for 2 years. Women need it on average for 3 years. But the averages are very dangerous. Those of us who like to do research in this area know that the real story is this very broad distribution of risk. While half will never need a high level of long-term supports and services, 14%, or 1 out of every 7, will need it for 5 years or more. And their care is going to cost $250,000 or more. As I said before, despite the common misperception, the vast majority of us get this care at home, which is where we want it. Of the 12 million people who need the care, about 700,000 live in nursing homes, about 800,000 live in assisted living facilities or other forms of residential care. Everyone else is at home. So what are the solutions to this? Well, the first one, of course, is we need to do something to improve our home and community care, both for those who are recipients of Medicaid and those middle-income seniors who are going to pay out of pocket. Remember I said before, there are 2 important demographic trends worth watching. The first is that we're living a long time. The second is that we're going to have fewer and fewer family members to care for us. In 2010, there were 7 people of caregiving age for every person who needed care. In 2030, there'll be only 4, and by 2050, there'll just be 3. And that's mostly a phenomenon of baby boomers who had very few children. On top of this, there's been a historic change in family structure. 25% of older adults live alone. Half of women 75 or older live alone. Fewer people are marrying. There are more divorces in later life. And of course, women continue to outlive their husbands. As a result, many more of us will live to old age and will have fewer people to care for us. So especially in the area of COVID-19, what are we going to do? So far, I know this talk has been pretty depressing, but I don't want everybody to just sit here and wring your hands and say there's nothing we can do. There are proactive steps we all can take to address our needs and the needs of our loved ones. So I want to give you a few ideas, both for the short term and then for the longer term. The first one, of course, you all know this as members of villages, but care from friends and neighbors, particularly in this time, is just critically important. That can happen through a village, it can happen through a faith community. There are many mechanisms for this, but we have to find ways to keep in touch with people, especially as we're more physically isolated. We need to find ways to reach out. Maybe that's phone calls, maybe that's Zoom, maybe that's standing on the front porch and having a conversation through a window. But there are ways to do it. You know, I was skeptical about Zoom dinners, but I've discovered you can do Zoom dinners with friends. It actually works. I thought, you know, who actually want to sit there and watch me chew, but people do. So, you know, try that. Look for volunteer opportunities. You know, they're not so easy to get now. You know, people who, for example, were volunteering in schools can't do that because the school systems are not allowing it. But there still are opportunities. If you sew, make masks. If you drive and don't mind going to the store, shop for those who can't. And advocate. Elected officials need to be pushed to pay attention. They've not done so yet, at least not sufficiently in my opinion, but we have an opportunity to make them notice. I have to say that in Maryland, and especially in Montgomery County, The needs of older adults are not at the top of the priority list. We all need to work harder to make sure that they get there. On a more personal level, I want to throw out a number of ideas for you. Some of these you've probably heard before, but they're especially important now. First one is, if you've been putting off preparing an advance directive for you and for your loved ones, please don't delay any longer. Create a living will, and just as important, designate somebody you trust to act as a medical power of attorney, which is sometimes called a home health or a healthcare proxy. Think about a do not hospitalize order if you or your loved ones prefer to die quietly at home and avoid the tumult of a hospital. It goes without saying that this is more important now than ever. This is just not a great time for an older adult to be in a hospital. And give copies of those documents to your appropriate primary care doctor and to that local hospital, and make sure they include them in your medical records. For those living in a care facility, get the management copies of those documents along with a MOLS, the medical order for life-sustaining care. The second area of planning ahead is specific to COVID-19. You need to make another plan if you're caring for someone. If you get sick, who is going to care for them? You're not going to be able to provide hands-on care for your parents if you have COVID-19. And you'll be in no shape to organize a backup. So work this out with families and friends now before there's a crisis. One interesting tool I found is something called Atlas Care Maps. It's a very cool little tool that helps you visualize who your supports are. And you can find it at a website called atlasofcaregiving.com. One word, atlasofcaregiving.com. It's a very interesting way to actually write down who is available to provide support should you or a loved one need it. Another thing to think about doing is join a support group. You know, family caregiving is really hard even in the best of times, and it's especially hard now. You may be caring for a parent who's living in a nursing home, or a spouse who's living in a nursing home or assisted living facility. You're unable to visit for weeks, and you're probably not going to be able to visit for months more. That's going to make you feel anxious and make you feel guilty. Don't try to manage this by yourself. Find others in the same situation and talk about it. Share ideas and maybe even a virtual shoulder to cry on. You may be able to find local groups through faith communities, through AAAs, the area agencies on aging, through aging and disability resource centers, through local nonprofits that support older adults, such as the Jewish Council for the Aging that I'm affiliated with, or with disease-related groups. National groups, there's one called daughterhood.org, or the AARP may be able to help as well. If you're caring for someone at home, there's some important things to think about. If you're using home care workers, you need to protect them, your parents, and yourself from infection. If you're hiring through an agency, make sure that it's providing its workers with personal protective equipment, such as masks, gowns, and gloves, and that it trains them how to use the equipment. If you're hiring directly, you may have to provide that equipment yourself, but it's critical that aides have access to that personal protection and that they use it properly. If your aides don't feel well, encourage them to stay home. Pay them if they have no sick leave, and few do. Remember that shift workers may be seeing other clients or working part-time in a nursing home. They're at very high risk of contracting coronavirus themselves and passing it on to others. So to keep them and yourself safe, you really need to make sure that they're okay. And of course, we've learned in recent days that you can be positive for the disease, but not have symptoms. So it's very important that they have that personal protective equipment, and also that they be tested if possible. If you're providing all the care yourself, and most people are, you face different challenges. You know, it's a lot harder now to ask a friend or a neighbor to come in to relieve you while you go shopping or take a break. But you can ask them to shop for you, even if it means leaving groceries outside your door, for example. And friends and relatives can provide some virtual relief with Zoom or FaceTime or even the telephone. So if you have to go out, you can ask a friend to just get in touch with your spouse, for example, and just chat with them while you're out for a while. If you're caring for a loved one who's living in a nursing home or an assisted living facility, you can't get to visit, but you can set up phone calls or video chats. And one thing to think about is involve as many family members as possible, including grandchildren. The grandkids can also send cards or notes, perhaps with photos enclosed. You also need to maintain a relationship with the staff. Check in regularly, ask management about infection control, ask if there's anything you can do to help, perhaps by donating equipment such as masks. One last bit of advice for caregivers: take a walk. Caregiving can become all-consuming, especially in this area of COVID-19. You need to take a break. You need to do everything you can to maintain your own health. A walk is a perfect solution. Everything else may seem like it's falling apart, but spring is beautiful, even if it's a little chilly out today. Try to enjoy it. Now let's think just for a second about the longer term. How can we make sure we're prepared the next time something like this happens? And it will. The role of nursing homes is going to change in profound and still unclear ways. The model that puts older adults and many of them with dementia in the same building as rehab patients newly discharged from the hospital is likely to change. Assisted living facilities are going to have to change their model to provide more complex care and to handle more medical issues on site rather than reflectively sending residents to the emergency department. We're going to have to design more robust home care. That means better transportation alternatives. Public transportation isn't going to do it for people, so we're going to have to think about better alternatives. It means more adult day programs. It means more Meals on Wheels and better food security. It means a safe place to live through home modifications. Most important, all of this is going to cost money, and we're going to have to find a way to get more money into our system to pay for these changes. You know, for now, many of these services are shut down. Senior centers are closed. Adult day programs are closed, but there are resources. The Jewish Council for the Aging, as I mentioned, the AAAs, they are available. Call them, ask for help. They can send you to resources. I just want to try to end on a positive note here. We're going to get through this. We have gotten through these kinds of challenges before. We'll do it again. And when we do, I hope we'll have a generational opportunity to rethink how we care for older adults. So I'll stop there, and I'm happy to answer any questions you've got. So thank you.
So if let's try it with the raise your hand feature. That will be easiest for me with this number of people involved. So if you have a question or a comment, Connie Rowe from Friendship Heights. So I will unmute her.
Hi. You mentioned Montgomery County, and of course we're here representing villages in Montgomery County, and I absolutely agree with you that that the aging issues are not at the top priority. Another basic problem is that with, for example, the issue of home health care. We have nothing but for-profit agencies. Well, there are maybe one or two that are not totally for-profit. But whereas the home care aides are getting maybe $10 an hour or less, which is a problem, they are charging $26, $30 an hour, which makes them completely unaffordable. And that's just one basic issue here in Montgomery County that we in villages are dealing with right now. So my question is, we are nonprofits. We obviously have to live within the rules of nonprofits. But as a nonprofit advocate now for many, many years, what can we do to get these kinds of issues to the forefront in a way that will make it possible for us to do something for our members and for the rest of the people in Montgomery County who are not members?
So he asked two questions. Let me try to unpack them. The first one, let me talk about the advocacy first. Older adults are a tremendously, potentially influential group in the county. There's lots and lots and lots of us, but we've been largely silent. The county council, the county executive don't hear from us. You know, they hear from the parents of the school kids, they hear from the teachers, but they don't hear from older adults and family members of older adults. So we need to advocate. Call them, write them, email them, let them know that the concerns of older adults are critical, that older adults, in fact, are the biggest victims of COVID-19, and that even when this passes, getting the necessary services in the county are critically important. And sure, there are other issues, but that one is a very important one. Now, keep in mind, one of the consequences of COVID-19 and the response to it is that state and local governments are going to be under enormous financial pressure. The debate over the next year or so, once we get past this first crisis, is going to be about cutting programs. So the challenge is not going to be so much getting them to do more for older adults. It's going to be to preserve what little they're doing. So it's critically important that we talk about it. Now, let me talk a little bit about your second question, which is the home health agencies. It is true. It is absolutely true that the agencies are charging $22 to $25 in this area. I haven't heard about 30, but 22 to 25 is about right. The aides, the $10 an hour is an average around the country. Aides here, I think, are getting a little bit more, but on average, you can assume that whatever a home health agency charges, the aides are getting about half. Now, that's not all the fault of the agencies. They have expenses. They have to provide some benefits. Many of them do, some don't, but they do provide benefits. They have to pay taxes for the aides, payroll taxes, other taxes. They've got to vet the aides. They've got to do police checks, that sort of thing. They have to do training. So it's not as if the home health agencies are keeping all of the profit. And some, I have to say, some home health agencies in this area are really quite good. Some not so good. But it is a fundamental challenge in this system. On one hand, the aides are not being paid enough. On the other hand, the cost, as you said, is too much for many families. So what do you do if you give the aides a raise? If you, for example, pay them minimum wage of $15 an hour, which some people want to do, that's going to only increase the cost for the families who can't afford to pay them the $10 or $12 an hour. So this is a huge challenge, and it's why I said we need to find ways to get more money into the system so that both the aides can be paid more and the family members who need the care can afford to buy it.
Great. Other questions? If you don't want to raise your hand, you're also welcome to put it in the chat box and I will pass those along. I saw Roy waving his hand, so I want to unmute Roy.
Doug, I would mention the discussion about cost. I lost a twin brother 11 years ago due to a botched heart surgery, and he lived for 7 months out at the Fairland nursing home on an incubator or ventilator, I guess it was. And 11 years ago, because he had the assets, he couldn't get any other assistance. It cost $32,000 a month to live in those conditions. For somebody who doesn't have that kind of money, what in the world can they do?
So ventilator care is enormously expensive, but even without that, even if you are living in a nursing home without the need for some special care, around here, you can expect to pay $130,000 to $150,000 a year for a high quality nursing home. You can expect to spend $80,000 a year and up for a high quality assisted living facility. You can expect to spend $5,000 to $7,000 a month for a good quality independent living facility. So it is enormously expensive. What do we do about it? Well, for a while, people thought a solution was private long-term care insurance. Long-term care insurance turned out to be very expensive. It turns out that very few people are buying it now. Last year, only about 60,000 people in the entire country bought private long-term care insurance. So it's not the solution that people expected. There is Medicaid, and Medicaid is available if you are impoverished and the care that it provides is not great. For example, for many people, if you're on Medicaid, you need to be in a nursing home because that's the only place that Medicaid will actually pay. And if you're in a Medicaid nursing home bed, you're probably sharing a room with a stranger. So it's not a great life. Most states, including Maryland, do have waiver programs for what they call home and community-based care. But in Maryland, in order to get on that home and community-based Medicaid program, you've got to be on a waiting list, and that waiting list is 2 or 3 years long. So that's not really an answer for many people. So what else is there? Well, you private pay. You just take whatever resources you have and you just spend what you've got until you run out, and then you go on to Medicaid. I've been working with several groups over the last few years, and we can talk more about this later if you'd like to hear about it, to think about a public long-term care insurance program. Something like Medicare, but it would cover long-term care as well as medical care. We've talked about this in the context of a catastrophic program. So people would be responsible for paying for the first part of their care. And then for people who needed very long periods of care, the government would kick in. That would require a tax increase. There's some people around the country who are interested in this. The state of Washington has just adopted a proposal like this. I've talked to a few people in Maryland, the Maryland legislature, who are a little bit interested, but so far there hasn't really gotten any traction in the state. But it is a possibility. It's a possible solution. But there has to be some way to get more money in this system. Otherwise, it's just going to fall apart.
So in the chat room, Arlene from Kent Mill suggests that when you pull money out of an IRA to pay for care, you may experience a big tax hit. And that may be something to consider dealing with as a legislative priority.
That's right. That's one issue. But remember that people who have significant amounts of money in IRAs are people with significant wealth. So you can provide some kinds of changes to the IRA rules, and that will help a few people. But the vast majority of people have IRAs of well under $100,000. It's not going to help them a lot. It'll help them a little bit, but not really very much. The people I worry about the most when I think about designing a system for financing long-term care are not rich people, and they're not really poor people because Medicaid is available for them. It's middle-income people. It's people who are school teachers or truck drivers or computer technicians. People who did everything they were supposed to do. They did everything right. They saved a little bit of money, and then they got the wrong disease when they got old. You know, the system we have now says that if you have a heart attack, Medicare will pay whatever it takes to treat you and take care of your heart attack. If you have dementia, where medical care is really not appropriate, it's really just personal assistance, Medicare pays nothing. They pay zero. That seems crazy. And that's why we have to think about getting some sort of a public system that doesn't discriminate based on the kind of disease you unfortunately got when you got old.
Other questions? See any raised hands? Here is Greg, you are unmuted.
Okay, it's Lois.
It's me.
Hi there.
Hi. If you die of COVID-19, will any medical schools accept your body for look-see?
Wow, I actually have no idea. That's a good question. I don't know. I will tell you that you know, there's been a lot of talk about autopsies, and in fact, we even before COVID-19 in the United States, we did almost no autopsies. The days of actually, you know, carefully determining why people died are long over. One of the challenges we've got with COVID is that a lot of death certificates won't say COVID-19. It's not actually at least not yet, it's not actually a code that a doctor can put on a death certificate. So people who die of COVID-19, their death certificates are probably going to say pneumonia. And particularly given the pressure that everybody's under right now, no doctor is going to spend a lot of time thinking about what he's going to write down on a death certificate. So we actually are going to know, it's one of the reasons why we know less than we should about mortality for COVID-19. But to your specific question, I don't actually know. It would be worth calling a medical school and asking them.
That's an interesting thought. Kathy, you are unmuted.
This is Miriam, and I can make a comment about the last question, that medical schools have restrictions about accepting bodies in cases of infectious disease. And I don't know that a policy for COVID has been developed yet, but I expect that they will not accept a body at this stage of the game if you die of COVID.
Interesting.
Great. Kathy.
Okay. Yeah. For the last, my husband died on Christmas Eve. And he had been in memory care for not quite 4 years, and he'd been in 3 different ones. And when you talk about the price range, but besides, and I'm very lucky that he died then, because I wouldn't be able to visit him now. And in addition to what's happening financially with the stock market, so I'm lucky that he died then. But I have a PhD and I have taught social and developmental psychology. And I did a lot of on the floor. Can you still hear me?
Yes, I can.
We
Okay.
can.
I don't know, something went
Somebody-
peculiar. Anyway, I did a lot of I did more than 4 years of on the floor observations at 3 different facilities. And I also took human resource management for medical at GW. One of the things that sort of a side issue that relates to all of this is how people that are going into management of facilities, they don't like the word, but homes for this, how they're very unaware and how little on the floor observation they can do at these places in management. I did more on the floor observation than the managers, because the managers have to deal with the bookkeeping, the whole building, the staff and the staff changes. And then we also have another issue, which is most of the staff in this area, many of them are recent immigrants. They're here legally. Of course, with COVID going on and the workforce changing and workforce demands, we may find that we have a different population. But so even when you have enough money for a home, each home is different. Each home has different issues.
No, that's exactly right. The variability in quality in nursing homes and for that matter, assisted living is enormous. When you think about these kinds of facilities, they really run the gamut. There are small facilities that are one-offs that are owned by a family. There are large corporate facilities. We have many around here. That are run by hedge funds. It's interesting. I once had a conversation with somebody who owned a number of nursing homes. And I had a real epiphany after talking to him, because he said, you know what? He said, this is not the care industry. This is the real estate industry. A lot of these facilities are actually leased. They're owned by real estate investment trusts and leased by operators from these real estate investment trusts. So their interest in caring for the residents is actually quite variable. Some of them are terrific. I have to say, I spent a lot of time, or at least I did before COVID, going in and out of facilities. And some of them really do care. And the management, they are on the floor and they know the names of the residents and they know the names of the staff. And it's really a wonderful thing to watch. Others, you're exactly right. You get the sense that nobody knows anybody. When I go into a facility to meet a resident, I've gotten to the point where I can tell in about 2 minutes whether or not it's a good facility. And it's got nothing to do with the decorations or how modern the facility is or how beautiful the lobby is or anything like that. It's about the aides. It's really all about the aides. And if an aide is taking me down the hall to meet a resident and it takes us 10 minutes to get there because the aide is stopping and saying hello to all the other residents, and she knows their name and they know her name, I can tell you that's going to be a great place, even if it's a little frayed around the edges. On the other hand, you go to a place and nobody knows anybody. It doesn't matter what it looks like. It's not a place you want to be. The old days they used to say, go in and see if it smells. Well, they've kind of taken care of that problem. But the other problems about, are they providing actual compassionate care? That's what really matters. And a lot of that is top down. A lot of that depends on the executive director. One of the things that happens in chains, Kathy asked this question. One of the things that happens with chains is the management style tends to be regress to the mean. So if they have a facility that's having a real problem, and then they have a facility that's doing very well, they'll transfer the executive director at the facility who's doing really well, send her to the place that's doing badly. And what that means is that'll pull up the place that's doing badly, but the place that's doing well will fall a little bit in quality, and it'll all end up at some average. One last thing to think about when you think about nursing homes is their profits. They lose money on their long stay residents. Medicaid pays a nursing home less than it costs the nursing home to operate a bed for a long stay resident. On the other hand, Medicare pays them far more than it costs them to do post-acute care. So to just give you actual examples, on average, Medicaid will pay a facility $200 a day to take a long-term care patient, and Medicare will pay them $500 a day to take care of a post-acute patient. So what do they want to do? Where are they going to put their energy? They're going to put it in the post-acute. One last thing about this is in the current environment, a lot of nursing homes have lost most of their post-acute business. A lot of that business was rehab after orthopedic surgery. So you have a hip replacement or a knee replacement and you go into a skilled nursing facility for a week or two to get rehab. That business has ended because there's no orthopedic surgeries being done right now. So that's putting nursing homes under enormous financial pressure at a time when their costs are going up and when they're having these outbreaks of this terrible disease. So when I said before that this was a system that was already dysfunctional, and this is just exposing the dysfunction, that was really what I had in mind.
Alan and Lisa from Potomac asked if you can cite sources where there are quality ratings of nursing homes, assisted living facilities, and home, I assume that's home health aid care companies in Montgomery County.
So there are no quality ratings of assisted living facilities. They do not exist. And regulation of assisted living facilities varies from state to state. It's impossible to know very much at all. In fact, nobody even agrees on what a definition of assisted living facility is. That varies from state to state. It's going to be different in DC and Virginia than it is in Maryland. Quality ratings on nursing homes you can get from Medicare. You can go to medicare.gov and they have something called Nursing Home Compare and Home Health Compare. And that will provide you with it's a star rating system. It's kind of 1 to 5 stars. And it will provide you with some very basic information on quality and safety. And to my mind, quality and safety is only the first thing you have to know about a facility. It's not all you have to know about a facility. So you can have a place that is a 5-star rating because it has, low rates of infection, few falls, and that's all important to know. It's good to know, but it's not the only thing you want to know. So the way I use these, the way I suggest other people use these, is if you have a facility that is consistently 1 or 2 stars, stay away. What it means is it's not a safe place. After that, the only way you can know whether a facility is a good one or not is you need to go in, you need to talk to the residents, you need to talk to the staff. Of course, that's impossible right now. But assuming we get past all of this, that's what you need to do. I'll give you one example of how quality ratings can be very misleading. One of the things that Medicare puts a lot of stock in is falls. They're very, very concerned about fall rates in nursing homes. Well, I could design for you a system in a nursing home where no one ever falls ever. And I will tell you, I would not want to live in that nursing home for all the money in the world. All of us who are living at home take on a certain level of risk. We do things every day where we're taking some chance. You carry the laundry basket down into the basement, you're taking a chance you could fall. But you know what? I want to live independently. I want to be able to do my own laundry. I'm going to do it. You get in the car and you drive on the Beltway. You're taking your risk. And it's no different for people living in nursing homes. They deserve a certain level of autonomy, and they have the right to take some risks. And if the consequence of that risk is that maybe they fall, that may not be the worst thing in the world. Now that's different from saying that you have a place that's dangerous. That's a different story. But when Nursing Home Compare looks at a fall rate in a nursing home, they don't distinguish between a place that's dangerous and a place that's giving its residents a certain degree of autonomy. And to me, that's a problem. So Nursing Home Compare is out there. It will help a little bit, but it's not the only thing you should be looking at.
Great. Other questions? Time, do I see any hands going up? Oh, got one. Okay, Greg.
Howard, you mentioned that the quality of nursing homes and assisted living facilities varies considerably. And I just wondered if you could give us some ideas of the top 3 or 4 or 5 that you would rate them.
I'd rather not. I don't want to. I don't want to get into the business of promoting particular facilities around. But I'll go back to what I said before. I mean, right now, today with COVID-19, you really have to avoid a nursing home if you at all can, or an assisted living, because it really is going to mean that your loved one, first of all, you're going to have to choose one without ever seeing it. And it also is going to mean that your loved one is going to be there alone, and you're not going to be able to visit. And that is, I fear, going to go on for at least a few more months, even in the best case. But once this is over, I think it does mean spending time, doing due diligence, spending time in the facilities, and seeing which one is really most appropriate for your family member. I have to say, one of the reasons why I'm reluctant is sometimes it depends on why a person is living in a nursing home. So, for example, there are facilities in this area that are very, very good at treating people who have had traumatic brain injury. There are other facilities that are really, really good at providing rehab after a hip surgery. There are other places that are really good on dementia care. And they're not necessarily the same places. So a lot of it depends. When you choose a facility, you've got to choose a facility that's most appropriate for the need of the person who's going in. It's the same with independent living. It's an interesting thing. People always ask me the same question. What's the best independent living facility around here? And again, it really depends. A lot of it is culture. There are some facilities in this area where the residents tend to be, retired academics and retired, State Department people. And that creates a certain culture. There are other people where the residents are retired lawyers and retired business people. And that's a different culture. And, you move into a place, a lot of what you do is with your new neighbors. You want to be in a place where you feel comfortable. And that is not necessarily just about the physical plant. It's also about the residents, which again is why if you're thinking about moving into a place, once we get back to more normal times, spend time there. Have meals with the residents, talk to them. Get rid of the marketing people who are going to want to follow you around, and just spend time talking to people who live there and see what they're like and whether you like them and they like you. So it's really a very subjective, once you get past these quality issues and safety issues, it's all very subjective decisions.
We have 2 questions in the chat that are related, so I will put those both out there. Arlene from Kent Mill asks how nursing homes are managing social isolation for long-term residents. And Jane from Silver Springs says that on a lighter note, do you anticipate that, and this is her word, the elderly will safely be able to resume cultural activities such as plays, concerts, museums in the near future?
Define near future. I think it is going to be months. In the best case, it's going to be months before these kinds of theaters and concerts and that sort of thing will even begin to be available. And then you need to make a decision about whether or not you feel comfortable attending these events. And that's going to be a very personal decision. You know, do you want to go at all? Do you want to go with a mask on? All of that. I mean, those are choices you're going to have to make. But I would be shocked if we're going to see any cultural events in this area before the fall. It would completely stun me. Maybe some outdoor events, that's possible. But, you know, going to the theater, going to movies, going to chamber music concerts, not going to happen for months ahead. And Doug, repeat the first question again.
So the first question was how nursing homes, and I presume she's also inquiring about other forms of retirement homes, are managing social isolation for long-term residents.
So it's a really good question with a really complicated answer. So there are a few steps that they're taking. The first one is, at the very beginning, what are they doing to make sure that people who come into the facility are not bringing COVID-19 in? And that requires testing with rapid results, which doesn't exist right now. So some facilities are saying to hospitals, we are not accepting COVID patients. So you have somebody who was very sick with COVID, they went to the hospital took care of them, and now they are recovering. They need post-acute care. Where do they go? And there are some facilities that are saying, we will not take you because we're afraid you're going to bring COVID-19 in. This is a huge problem. A group of us actually worked on a paper that was published just the other day, suggesting that perhaps what we can do is create COVID-only facilities, so we don't have this problem. For those facilities that are accepting people who may be COVID positive or for whom they don't know whether they're COVID positive or not, facilities are doing what they can given the physical plant that they have. So, for example, you can at least separate by corridor or by floor the COVID patients from everybody else, or the unknowns from everybody else. You can separate the long stay residents from the skilled nursing residents. Some facilities have done that for years. There are other facilities that don't, where one room will have a skilled nursing patient and the next room will have a long stay resident. That's a very bad practice, and that I hope is changing in facilities. Of course, we don't know, but I hope it is. Some places aren't doing anything more than putting plastic sheeting up to separate people. I mean, that's the best they can do given the physical plant that they have. You know, one of the challenges is this is not a time where you can do, you know, major construction projects. It's impossible. So they have to live with what they've got. The other thing they're trying to do is separate the staffs. So what some places are doing is they're designating COVID-only staff people. I hope they're paying them a premium, although I don't know that. And they're testing them regularly. They're keeping them separate from the other staff, because one of the problems that I think we're going to discover is what was happening is you would have an aide who would go into a COVID positive patient's room, perhaps not knowing that she was COVID positive, do what she needed to do, and then go into a COVID negative patient's room and pass the disease on to her entirely unknowingly. So separating staff is another thing that they can do to prevent that from happening. But it's all being jury-rigged. I mean, this was not something people were prepared for. I will say there is some early evidence that facilities that were doing a good job with infection control before are having a better luck with this now. But again, we're not going to really know about that until this is over and people are able to go in and actually do the research.
Which we hope will be soon. Connie, I will unmute you.
You said that you were involved in advocacy and that you might talk about that some. Would you explain to us what you're involved in?
Sure. So I have to say that as an employee at the Urban Institute, which is a nonprofit, I don't advocate. but I do provide information to people, to legislators and other policymakers who are looking for support, looking for assistance. So what I focus on a lot is this whole issue of financing long-term care. And as I mentioned before, most of the people who do this work have come to the conclusion that the system we have now is vastly insufficient. And the experience we're having with COVID-19 is just more evidence of how bad it is. So how do you get more money into the system? And the idea is to create a public program that would provide at least a catastrophic benefit for people who have significant spells of long-term care need. So the idea is that a family would be responsible for paying for part of the need, perhaps with insurance or with a reverse mortgage or with any savings they have. But then once they triggered a period of time, say a year or two, and loved ones needed care for more than that period, then a public catastrophic program would kick in. This was an idea that has been very slow to take hold. About 10 years ago, there was actually some legislation as part of the Affordable Care Act. There was actually a piece of it that would have provided a program like this, but it was never admitted. They could never figure out a way to make it work, and the Obama administration actually abandoned it. But now there's a lot more interest in it, even before COVID-19. A number of states are exploring this. California, Michigan, Illinois, Minnesota are all looking at whether or not they could create state programs. There are some politicians on the federal level. Pete Buttigieg, when he was running for president, actually adopted this proposal as one of his part of his healthcare and aging agenda. The chairman of the House Energy and Commerce Committee, Frank Pallone from New Jersey, has proposed a bill something like this. The chairman of the House Ways and Means Committee, Richie Neal from Massachusetts, is thinking about something like this. So there is some interest among some lawmakers about doing a proposal like this. Joe Biden has not been interested in anything this ambitious, at least not so far. President Trump actually had stood up an interagency task force about a year ago to look at ways to make long-term care insurance more marketable. I was actually asked to testify before that committee. They were supposed to put out a report last fall, and they never did. I suspect we're not going to see it now. But it's an issue that's of enough concern that even the Trump administration realized that they needed to say something about this, even though nothing, as I said, nothing's come of it. So there is a growing interest in reforming the way we finance long-term care, but we've got a long way to go. And as I said, to go back to back home for all of us, Maryland has so far shown very little interest in doing anything like this.
Other questions or comments from anyone? I don't see any hands up. Let me just take a scroll through here real quick and see. Great. It looks like that's it. We don't have any other questions. Thank you very much, Howard, for doing this. Depending on my motivation, I'll try to thank you by leaving some cookies on your doorstep.
Thank you. Thank you, Doug, and thank you all for taking time this morning to chat. It's been good to hear from you, hear your ideas, and hope we can talk again soon.
Great, thanks so much. And for people from other villages, we will be doing a series of different events from now until the foreseeable future that are of interest to seniors across the county. This is open to all members of all villages in the county, and so we encourage you to join us for that. Your leadership or your executive directors are aware of these. If you're doing something in your village that you think would be of interest to others, we have the capability of putting that up on Zoom as well. If you are not currently using Zoom, we can help out with that to some degree. I believe our next event I don't have a specific date for it, but it's going to be, I believe, the second Wednesday of May. And it is about a senior woman who is in the midst of bicycling around the world. We have another event scheduled for June 10th, which will be the attorney who argued the marriage equality case at the Supreme Court 5 years ago, and taking a look at that decision and what went into the background of that. And we will be adding some more things as they come up, so feel free to check in with us. You can always send me an email at doug.gaddis@silverspringvillage.org. And we're happy to be able to share this with you. And this Zoom event has been recorded, so we will, depending on my ability to work the technology, we will try to make that recording available either on our own website or possibly by email to various villages. If you're interested in that, you can just reach out to me and let me know. Great, so I think we are finished. Margot has a question, I think.
Margaret says thank you for facilitating the meeting. It was very, very informative. Thank you, Howard.
Thank you, Margot.
Great. If there is nothing else from anyone then, everyone feel free to go have lunch, probably in the safety and happiness of your own kitchen. So bye, everyone.